Another important topic, which is medically and surgically very important to know the significance and also the treatment strategies, is the inflammatory bowel disease. Now, if we talk about the inflammatory bowel disease, there are two important diseases which are basically a part of the inflammatory bowel disease. And one is the Crohn disease and other is the ulcerative colitis. But specifically, when you talk about the complications of the inflammatory bowel disease, it's the Crohn disease which actually has got manifestations and the complications which are being treated surgically. Now, before going into the surgery and the surgical options, we have already covered this topic in the medicine, but let me just give you the overview of the Crohn disease. So one thing I have already emphasized is that the Crohn disease is the inflammatory bowel disease, and it's a chronic inflammatory bowel disease, which can be the remissions and the relapses. They can come to you in acute form, and it's a transmural inflammatory process. That means the inflammation is not only affecting a single area, but it's through and through the full thickness of the intestine can be affected in the Crohn disease. Now, if we talk about the incidence or the ratio, it's much more common, at least like 2 times more common in women as compared to the men. And the other extra-intestinal manifestations of the Crohn disease include like malidiosis, and it can be primary sclerosing cholangitis, and there are some other. The chances of the malignancy can be associated with the Crohn disease, and like especially the like lymphomas. So talking about the Crohn disease, it's already been discussed that it's a chronic inflammatory transmural infection, or it can actually affecting the full thickness of the intestine, and it can be anywhere starting from the oral cavity to the anal canal, but most specifically and more precisely, the terminal ileum is the part which is most commonly affected, and the colon as well. The anal canal and the perianal region with mucocutaneous complications, they can also be a part of the Crohn disease. Now, if we talk about the difference from ulcerative colitis, so we know that it's a transmural infection, and that is basically a mucosal chronic inflammatory process. Plus, in case of the Crohn disease, there is a lot of fibrotic changes, and the patient may present to you with the fibrotic stenotic changes. And because of the recurrent infection and inflammation, there is a lot of fibrotic thickening, and because of that, there is luminal narrowing. And because of this luminal narrowing, the patient may end up in acute intestinal obstruction, or the patient can actually have perforation. Now, when you talk about the Crohn disease, most commonly, the patient is going to present to you with with abdominal pain, and the pain is now we are talking about the Crohn disease, not a complex one, and not a complicated one. A simple Crohn disease is basically presented to you with dull like abdominal pain, and especially the patient will feel the pain postprandial. Whenever he takes everything, he eats everything, the patient experiences the dull like abdominal pain, and there can be mild episodes of diarrhea, or there can be relapses and remissions, and sometimes patient can actually present to you with fever, and the patient will have a chronic history. Maybe he would be saying that I'm experienced these symptoms for the past 6 months. There are 2 important decades for the manifestation of the Crohn disease. Usually it's between 20 and 45 years, and one is a late presentation, like in 70s of the age. And now, when you talk about the Crohn disease, most of the time, the medical treatment is sufficient for the relapse and remissions, and you combine the medical treatment with the monoclonal antibodies, and you give the immunomodulatory agents, and you also combine with the steroids for the active or the acute inflammatory part of the Crohn disease. You try to deal with the steroids, and for a maintenance therapy, you try to give your patient supplemented with monoclonal antibodies or immunomodulatory agents. Now, there are complications, and the complications can be in the form of fistula formation. There can be enterocutaneous fistulas. There can be aleovesicular fistulas, or there can be aleocolic fistulas. There can be stricture formation, and these strictures are formed because of the chronic inflammatory process, and because of the fibrotic thickening. And because of this fibrotic thickening, there is a luminal narrowing, and because of this luminal narrowing, the patient can actually present to you with acute or subacute intestinal obstruction. Now, sometimes the patient can have ulcerations as well, and these ulcerations, because of that and their necrosis, and because of the ulcerative wall, the patient can end up with a perforation. And if there is, most common site for the perforation is ileum, and the patient can actually present to you with the signs and symptoms of acute appendicitis, and you may suspect acute appendicitis. And when you open up the patient, you see the ileal mass, or terminal ileitis, and then you have to decide preoperatively if you're gonna go for surgery, or you want to put the patient on antibiotic and immunomodulation monoclonal antibody therapy. Now, one thing to emphasize here is most of the time this disease is kind of immune system related disease, and we the two hypotheses, or the two theories which are trying to explain, is there's some kind of defect in the cell-mediated immunity, and because there is defect in the suppression of the T cells, and we know that the suppressive T cells, they actually limit us, and they kind of maintain a check and balance in the process of inflammation. But if the suppressor T cells are not working properly, or there's a defect in the suppression, then the process of inflammation will go on and on. And because of this inflammation, it will convert into the chronic inflammatory process, and there would be obviously the complications of chronic inflammations and the fibrosis, and the patient will end up with the Crohn disease and ulcerations. One thing to know here is, in case of the Crohn disease, we actually encounter with skip lesions, like a part of the intestine, whether it's a small intestine or it's a large intestine, that is ulcerated, then the normal healthy part of the intestine, then again the diseased part, then normal, and then these are called as skip lesions. And the main problem in case of the skip lesions, because this is a disease which is not affecting only a segment of the intestine, it can be anywhere starting from the oral cavity till the anal canal, and then if they're widespread skip lesions, then you are concerned about how much of the segment of the intestine should be resected, because if a large segment of the intestine is to be resected, then there would be some other complications like vitamin B12 deficiencies and folate deficiencies because of other resections, and there are multiple short gut syndrome can be one of the complications, and you have to weigh between the benefits and the disadvantages of the surgery.